So our last speaker before we start the panel presentation is Dr. Tim Miller, who's part of the leadership group in the Department of Anaesthesia at Duke University Medical Center in North Carolina, but also the president-elect of the American Society of Enhanced Recovery. And Tim's going to talk to us about the challenges of fluid management in particular. Tim, welcome.
Thank you, Monty. Thank you, everyone. All right, so I do have some disclosures. So I've written a number of guidelines on fluid management. And one of the first things that you want to do when you write some guidelines is get something that everyone's going to agree on. And I think we would all agree with these two statements. On a broad basis, the goals of fluid management are to maintain central euvolemia, so a nice full circulation to perfuse our tissues at all times during the procedure, and to avoid fluid and salt excess. Avoid that Michelin Man patient who's put on 5 to 6 kilos. Imagine that. Some of the literature is 5 to 6 kilos during the course of the operation. And just imagine any of you, if you were 5 kilos heavier tomorrow after surgery than you are today, how you would feel. And that's how we abuse some of our patients with fluid management. And of course, this facilitates the delivery of oxygen to the tissues without causing harm. You can't give any fluid talk without showing this well-known U-shaped curve to describe what we're trying to do, first drawn by Bellamy back in the BJA in 2006. And what this describes, complications on the y-axis, volume load across the bottom. If we have episodes of hypovolemia, we're going to get adverse outcomes. And equally, if we give too much fluid, we can get adverse outcomes. So what we want to do is to keep our patient at all times in that optimal zone. When we're talking about enhanced recovery, the majority of enhanced recovery pathways are major abdominal surgery. And I think the gut is particularly at risk. If you have episodes of hypovolemia, one of the first things you'll do is shut down your splanchnic circulation to maintain your core circulation, to maintain blood pressure and perfusion of your vital organs, your brain and your heart. And I can't tell this story without the anecdote of Monty's study, which is probably about 25 years ago now, when Monty was maybe longer. I don't want to age you, Monty, but when Monty was a keen resident, they decided to do a study on each other where they put in arterial lines and 14-gauge catheters and bled out 25% of their blood volume. Probably wouldn't get IRB approval these days. But what they found is that heart rate and blood pressure didn't really change, whereas to compound the misery, they also put nasogastric tubes down each other and measured their splanchnic perfusion. And when you lose 25% of your blood volume, your stroke volumes, if you measure a flow indices, drops, and your splanchnic perfusion drops when your blood pressure maintains normal limits. So one of the first things you'll do when you become hypovolemic is shut down your splanchnic circulation, which is bad for GI perfusion. More commonly, if we give too much fluid, you get that little bit of puffiness under the skin, puffiness around the bowel wall, and bowel wall edema. And that is also associated with adverse outcomes, and there's been a number of studies in the restrictive arena which have shown this. Perhaps this most well-known one was by Brandstrup. It was called restrictive study, but notice I put that in inverted commas because this study really showed the dangers of fluid excess. So they had two groups. The only thing they changed between the two groups was the fluid management. You can see their restricted group had about 2 to 3 litres of fluid on the day of surgery, so about what we would think now as a sensible amount, whereas their liberaler group had the old-fashioned 7.5 to 10 mils per kilo per hour of fluid. So they got 6 to 7 litres of fluid on the day of surgery. Those were those patients who were 6 kilos heavier than they were the day before. And notice the difference in complications just by changing the fluid regime, halving of major and minor complications when we avoided fluid excess. So this led to this paper by Daniel Chappell, and this is the approach that we largely follow at Duke, suggesting a rational approach to fluid therapy, and just the title alone suggests that he thought behavior before this was irrational, which I think it was. That maintenance fluids should be, crystalloid we use on a pump, approximately 3 mils per kilo per hour based on ideal body weight, to replace your whatever deficits you have. I think they're fairly minimal now in enhanced recovery, insensible perspiration, urine output, And he also goes into some detail about how there is no such thing as the third space. If you want to read the paper, you can read more about that. But basically, fluid is either intravascular or it goes into the interstitium. We don't need this concept of an all-consuming third space where fluid disappears. And in some patients, that's enough. But in many patients, if you want to individualize fluid therapy, you can do goal-directed fluid therapy. And this is what we do at Duke. We use a colloid. I think the evidence for that is weak. A crystalloid is an alternative approach. But you try and individualize your fluid management. So why goal-directed therapy? Well, as I've mentioned, we've used blood pressure for many years. And back in as long ago as 1928, they said it's a source of regret that the measurement of flow, i.e. stroke volume, is so much more difficult than the measurement of pressure. This has led to an undue interest in the blood pressure manometer. I.e., in Monty's case, when he lost 25% of his blood volume, if we'd been able to measure flow, we would have noticed that decrease and we'd been able to intervene early. And obviously, over the last 20 years, we've had a number of devices that can now measure stroke volume, so we're able to do goal-directed fluid therapy and optimize stroke volume. And on a very basic principle of goal-directed fluid therapy alone, not the hemodynamics, the idea is that if we can measure stroke volume, we can optimize patients on their Starling curve. If they're on the steep part of the Starling curve, they've got recruitable stroke volume. You give typically 250 mils of fluid, and they'll have recruitable stroke volume. Their stroke volume will increase by greater than 10%. Once they get to the top of their Starling curve, you give the same fluid challenge, and the stroke volume will no longer increase by 10%. And the idea as you go through the case is that you're able to optimize their stroke volume. It may take a couple of fluid challenges at the start to get them to the top of their Starling curve with 10% increases. And then you can stay there. If you have some blood loss and a decrease below whatever trigger you set, you can then use that as a time to give a further bolus of fluid. And this may be before you've actually seen any hypotension. You've just heard the surgeon's sucker. And back in 2011, so merely 7 years ago, almost every single study that had looked at goal-directed therapy was positive, with an overall reduction in complications of around half. TJ and I wrote the accompanying editorial to that meta-analysis, and we suggested a minimally invasive cardiac output monitor should be considered in all major surgery. Interestingly, we also said that firstly you should optimize volume status using fluids, and if the patient was still hypotensive, you should consider the use of inotropes or vasopressors if you have a low SVR. And we'll come back to that later because that's more of a hemodynamic approach. At around the same time, the NICE guidelines, the National Institute of Clinical Excellence in the UK, published this guideline. It was referred to the esophageal Doppler, which the majority of studies at the time were using this device, but most people took it to mean the technique of goal-directed therapy in general. And as you can see, they showed the evidence that it reduced complications, reduced the use of central venous catheters, reduced length of stay, and its use was supported for all major surgery across the National Health Service. However, things change quickly. I like this slide because, 10 years ago, I still think it's amazing to think this, 10, 11 years ago, there was no iPhone. Believe it or not, there was no iPhone. And any studies that were done on workflow or productivity 12 years ago will have very little relevance to today. And 10 years ago, there was no enhanced recovery. So all those studies that I showed you were not done within an enhanced recovery pathway. And the way we manage patients has changed enormously over the last 10 years. So the real question I think we've got to ask now is slightly different to those older studies, is does goal-directed therapy offer any benefit over a restrictive fluid approach within an enhanced recovery pathway? Because with our traditional surgical pathway, and this is a graphic Mike Scott, who's at the back, and myself put together, a traditional surgical pathway in the blue line, patients were hypovolemic when they arrived, and then we gave them lots of fluid. So when you put together a fluid algorithm using goal-directed therapy, it was fairly easy to show a benefit. Whereas with enhanced recovery, if patients aren't hypovolemic, they're having laparoscopic surgery, we've got a sensible fluid regime, it's going to be harder to show that benefit with goal-directed therapy. I'll illustrate this with a couple of studies. As TJ went before me, I'll use one of his classic studies, a well-performed study, obviously, which occurred at Duke back in 2002. But it just illustrates how quickly things can become a little bit dated. So 100 patients, major abdominal surgery, expected blood loss greater than 500 mils. Even that you may find hard to recruit to those criteria in this day and age. But there was no enhanced recovery. It was all open, all patients were fasted, had bowel prep, there was no early feeding, no early mobilization. And what they did, they had a control group and the goal-directed group. And the goal-directed group used the classic 10% algorithm using the esophageal Doppler. Compare this to a study which was published more recently by Srinivasa. This is a very well-run centre in Auckland. The important thing is they used exactly the same 10%, or very similar 10% algorithm, but almost everything else that they did had changed. So you can see again, it was a smallish single-centre study, well-established enhanced recovery pathway, no routine bowel prep, carbohydrate drink, epidurals, early feeding, early mobilization. The control group had a very sensible regimen, max 1,500 mils of crystalloid, max 500 mils of colloid. And the only difference in the goal-directed group was, again, they had the max 1,500 mils crystalloid baseline and then the same 10% algorithm. And when you look at the results, you can see at TJ's study, both groups had about 5 litres of fluid. They were able to optimize, i.e. improve the stroke volume in the goal-directed group compared to the controls very early, reduction in those GI complications, reduction in length of stay. Whereas the Srinivasa study is a lot of laparoscopic surgery. They had less than 2 litres of fluid. There was no significant difference in the stroke volume between the two groups and no difference in length of stay. So what does this show? Well, it shows that overall perioperative care has improved over the last 15 years. That's not surprising. And the benefits of a single approach, such as goal-directed therapy, but I also think it would apply to carbohydrate drinks, anything we do is smaller because overall care has improved. The length of stay in the Srinivasa study was around 2 to 3 days in both groups. And the patients probably never became hypovolemic. And if you don't become hypovolemic, the benefits of a device that's going to predict or spot hypovolemia earlier are going to be more limited. So what we need to do is to come on to larger multicenter studies. And this is the largest multicenter study that's been published so far by Rupert Pearce. They looked at medium to high-risk patients in the UK. It was a pragmatic study using goal-directed therapy, and it had the investigators' worst possible result. It was slightly underpowered. The original complication rate they wanted was around 45 to 50%. So even though the curve started to separate and separated throughout, it got a p-value of 0.07. So I'll leave you to decide whether that was significant or not. According to the p-value gurus, it wouldn't be statistically significant, but I know which group you'd probably rather be in, and that was the intervention group. They did an accompanying meta-analysis, and as you can see, the previous meta-analysis, the odds ratio was 0.44 now. Overall, the benefit of goal-directed therapy compared to control has decreased as perioperative care has improved. So where are we now with goal-directed therapy? I think undoubtedly enhanced recovery has made fluid management easier. We get these carb-loaded, hydrated patients doing laparoscopic surgery. As I mentioned, small single-center studies, harder to show benefit. The control group management has also improved. The optimized study I just mentioned did show a reduction in complications but was underpowered. Importantly, there's no evidence in any of the studies that goal-directed therapy causes harm. It's just when it's going to have benefit. And complications are very expensive. And Sol's already mentioned this. I'll just show this other study. This was a large study, hundreds of thousands of patients. But you can see colectomy in the middle there, 20,000 patients. This was 100 patients at 200 centers. And see, if you had a complication, it increased your costs on the right there by about $30,000. So when we're trying to budget for these items, I don't think we can forget how expensive complications are. The other thing I think is very important when we look at this literature is, yes, we're getting better at what we do, but this is in patients that are in studies, and it's actually quite different when we look into the wild west of what actually happens in the real world. And this was aptly illustrated by this study, which looked at over 5,000 patients at two fairly prestigious institutions, UC Irvine and Vanderbilt, fairly recently in the enhanced recovery era, 2009 to 2012. Importantly, they had no guidelines on fluid administration. And when you can look at the amount of fluid that was given, again, this is a fairly busy slide, but if you look in the middle at colectomies here, you can see that half the patients at both institutions, UC Irvine is blue and Vanderbilt is green, half the patients received between 4 and 10 mils per kilo per hour of fluid. The other half of the patients received 15, 20, 25, 30 mils per kilo per hour of fluid. And what do you think the biggest predictor of the amount of fluid that the patients were given was? Any guesses? It was the anesthesia provider, 5-fold different from one day to the next. And this must be incredibly frustrating for a surgeon when, depending who's their anesthesiologist that day, can dramatically change the amount of fluid that was given, sometimes from 700 mils to 5.5 litres for a very similar 4-hour case. And we have to, I think, have a hard look at ourselves when we do things like this. So can we just use a restrictive approach? Can we just restrict fluids? Do we need goal-directed therapy? We've got our theoretical curve, which on the left side is a tick up, showing that both restricting and giving too much fluid is harmful. And now we have some actual data that shows that this is correct. This is from Monty and Julie Thacker from the Premier database. And you can see in reality this U-shaped curve is replicated. There's an increase in length of stay, total costs, and post-op ileus. And I think this data is important because in the enhanced recovery world, it's become trendy to give less and less fluid. People are doing a more and more restrictive approach. When I go to meetings, some people say, I only give a litre of fluid for my colorectal cases. And I even had someone come up to me and said, I don't give any fluid at all. My patients, they all get their carbohydrate drinks. They can drink up to the time of surgery. My surgeon takes 2 hours. They eat immediately afterwards. I don't need to give them any fluid. And he thought that was cool. So I do think it's important that we do have this tick on the left side. This study was replicated from MGH. Again, large number of patients, nearly 100,000. The important thing in this study is they particularly looked at acute kidney injury, and they really saw an uptick in acute kidney injury in the patients that got the least fluid in their first quintile. So Monty and I put together where we think things are now, and I think the evidence is a risk-adapted approach. Surgical risk, patient risk. If you've got a low-risk patient having low-risk surgery, you can probably just do a zero-balance type sensible fluid approach. As patient and surgical risk goes up, I think the benefits of goal-directed therapy increase. Interestingly, why I say this, we do goal-directed therapy for all patients at Duke within our enhanced recovery pathway. So you may be thinking, he's just published this. Why do they do goal-directed therapy in all patients in their pathway? This, I think, is the state of the evidence. With regards to implementation, it's much easier if you just implement a standardized approach. So we do this in every patient. Some of the patients are in that lower risk group, but we still do it because it's the part of the way we do things. The monitors are in the room, the residents get trained, the CRNAs get trained. And I'm reluctant to start doing a risk-adapted approach because then I think people will be like, nah, not going to do that. And it will become much more variability will enter the system. We can discuss. TJ mentioned POCI, the Perioperative Quality Initiative. I was lucky enough to organize this first conference, which happened in Durham, in North Carolina. And we put together this infographic. On the left side, this is the entire pathway that we believe for fluid management. Starts preoperatively by minimizing NPO status, minimizing bowel prep and using isoosmotic agents if you're going to use bowel prep, risk stratifying our patients, giving a carbohydrate drink. And then, as you say, the risk stratification was really very similar to the risk stratification that Monty and I published. And then, importantly, post-operatively, get those IV fluids down, get the patient eating and drinking as soon as you can. And a lot of our patients will have their IV down before they leave the PACU, and again, get them drinking, eating, and mobilizing. Because there's no point in us doing the most perfect intraoperative management if they get the drive-by shootings with saline, as Monty likes to call them, post-operatively. So we want to have the benefits of what we're doing, get up, get drinking, get eating, and start to recover. This is a very nice editorial that was published in the BJA recently by Gary Minto and Jonathan Wilson, two fairly dry Brits. As you can see, Brexit is obviously fairly topical in the UK, so they decided they would go for Flexit or fluid exit, which is basically what we need now. So we don't need any more small single-centre studies. We need to stop giving too much fluid and start doing large, pragmatic, which is everyday life, not what happens in a randomised control, fluid studies. Unfortunately, there are going to be two coming. Optimise 2 is a pragmatic study of 2,500 patients having major elective surgery, which is going to be at centres in the UK and around the world. And even more ambitiously, Mark Edwards from Southampton is leading Floella, which is using the existing database for emergency laparotomy in the UK. A lot of this study is actually being run by trainees, because they have trainees in every hospital in the UK, trying to recruit 7,500 patients having emergency laparotomy. I take my hat off to Mark. If anyone wants to help get involved in that study, I think this is going to be a hard study to do, but he's making good progress as far as I know. So just for the last few minutes, how are we doing for time? I'd just like to touch on hypotension, because I think, as Desiree mentioned, I think this is very topical. Does hypotension matter? And we had another POCI, which took place before the EBPOM meeting in London last year, really examining this subject of hypotension with Dan Slester there from the Cleveland Clinic, who's done a lot of this work. And he really got us thinking about hypotension with a series of papers that came out of the Cleveland Clinic, looking at their very large database. They looked at nearly 60,000 patients and looked at the lowest BPs that were recorded and looked at outcomes, particularly acute kidney injury and MINS, so myocardial injury after non-cardiac surgery. And the data is very, very interesting, and this led to the sort of recommendations from our POCI. If your mean arterial blood pressure goes below 65, even for periods of time as little as 1 minute, you see an increase in acute kidney injury and MINS, both in major non-cardiac surgery. And interestingly, these graphs are almost identical when they used thresholds such as 20% from baseline as when they just used a figure of 65. So the recommendation was to use 65 because it's an easier target. So this is quite compelling data and quite interestingly, and it's changed my practice, because even brief periods of hypertension, when you look at big databases, potentially can cause harm. Another important point to note is that a third of these incidences of hypotension were between induction of anaesthesia and incision. So it's quite hard to blame the surgeon for that. So that, as we know, is us. That's hypotension after induction. But of course, this is just an association. There's no causality. And we know that sicker patients have more complications, and sicker patients are more likely to be hypotensive. It's intriguing, but it's just an association. So then came this study that many of you may have seen in JAMA by Futier, which was the first study looking at an intervention for blood pressure. So they had nearly 300 patients, and they randomized patients to either their control group, and importantly, the control group only got ephedrine when the blood systolic went down to 60, or an individualized blood pressure group where they kept systolic blood pressure within 10% of baseline using a dilute peripheral norepinephrine infusion. And they saw dramatic results with a significant reduction in complication using this individualized treatment. There's one very important caveat, which is quite hard to spot in the paper, was that all these patients had goal-directed therapy. They were all fluid optimized before they started the blood pressure control with the norepinephrine. I think a danger, if anyone reads this paper and doesn't realize that, a danger of an unintended consequence is just people just start squeezing hypovolemic patients thinking that they don't want to have hypotension. That is not what they did in this paper. They fluid optimized, and then if they were hypotensive, they added in norepinephrine. We had quite a debate this morning about the fact that they used norepinephrine, and how many of you routinely use norepinephrine as your pressor of choice? Oh, there is. My fellow does. Thank you, Elena. Didn't realize that. And we can come on to that in the debate. But I mean, I think the fact that they didn't just use phenylephrine, which perhaps is not the most sensible agent to choose. They chose norepinephrine. It could be that dopamine would be a sensible agent to choose if you were going to use this type of approach. And then finally, this last trial, which came out very recently, that Monty was an author on. Again, we discussed at some length this morning. This is where I think the state of the literature is now. This was a multicenter randomized controlled trial, 420 patients, goal-directed, not fluid therapy, but hemodynamic therapy with fluids and potentially vasopressors and inotropes. The algorithm was on the right, so all patients were fluid optimized, but then if they were still hypotensive, they added some vasopressor. If they still had a low cardiac index, they added some inotrope. And this was actually in, again, multicenter, but in low to medium risk patients. And you can see, again, like some of the earlier goal-directed therapy literature, significant reduction in length of stay, significant reduction of complications, including AKI and wound infection. And encouragingly, it was the same approach that TJ and I recommended in our editorial back in 2011, and also the same approach that is recommended in the recent POCI guidelines. So, final slide. I think this hemodynamic framework makes a lot of sense. We ask, is there a clinical problem? And then we look at our monitors to see the information that we can get to help us treat the clinical problem. Number 2 is very important, use your brain. So it's not just following an algorithm, it's using your brain to look at the entire information that you're getting. And then if you think the patient's hypovolemic, give fluids. If they think they're fluid optimized and they're still hypotensive, use vasoconstrictors. And obviously if the index is low, you may want to give something to increase contractility. And then you repeat. So to summarize, I think the literature has evolved. I think there's going to be more trials coming out in the near future as it further evolves. There's no real evidence it causes harm, and I think there's a significant body of evidence that it's beneficial. Thank you very much.